Bismillahirrahmanirrahim. This is the fourth video in the series on the bone tumors, and this is about the tumors of uncertain origin and other tumors. The references are these. By the end of this video, we will be able to answer the solution to these clinical scenario. One is a 32-year-old woman present to your office complaining of pain in her right knee joint, and an 11-year-old boy present to the emergency department complaining of a painful swollen mass in his right leg. He denies an history of trauma to the leg. Earlier we have discussed the chondrogenic and osteogenic tumor. There is another category of the bone tumor, that is the tumor of unknown origin, and they comprise of benign and malignant tumor. The benign tumors in this category are giant cell tumor and aneurysmal bone cyst. The giant cell tumor involve epiphysis of the long bone, and they affect individual between the age of 20 to 40 years. The aneurysmal bone cyst affect proximal tibia and distal femur and the vertebra, and the individuals are affected during the second decade of the life. The malignant tumors are Ewing sarcoma and adamantinoma. The Ewing sarcoma affects the diaphysis of the long bone, and the individuals affected are affected in their second decade of their life. The adamantinoma affects tibia, and individuals are affected between the age of 30 to 40 years. There is another category of the bone tumors, that is the notochordal tumor, which accounts for about 5% of the tumors of the bone. This is a malignant tumor, and the common tumor type is chordoma. And the common location for this chordoma is clavus and sacrum. It affects people between the age of 30 to 60 years of age. The malignant tumor of unknown origin is Ewing sarcoma. This is a malignant bone tumor characterized by primitive round cells without obvious differentiation, and this Ewing sarcoma accounts for about 6 to 10% of the primary malignant bone tumor. It is the second most common group of bone sarcomas in children, and it affects children below the age of 20 years. 89% of the cases are within the first 2 decades of the life. It is twice as common in male than in female, and more common in Caucasians. The diaphysis of the long tubular bone, such as femur and flat bone of the pelvis, is involved in the skeletal involvement of this lesion, while this lesion, this Ewing sarcoma, tend to affect or involve the extraskeletal sites also, and these accounts for about 10 to 20% of the cases. It presents with a painful enlarging mass, and the affected site is tender, warm and swollen, and there is association of the systemic findings which mimic infection. These findings are fever, increased ESR, anemia and leukocytosis. In a large series of the Ewing sarcoma, the pelvis was affected in quarter of the cases, but when considered cumulatively, the long bone, the shaft of the long bones, they outnumbered this. The cell of origin in Ewing sarcoma is not certain. However, mesenchymal stem cell and primitive neuroectodermal cells are considered as a cell of origin. In more than 90% of the cases, there is a balanced translocation between Ewing sarcoma 1 gene on chromosome 22 and friend leukemia integration 1 transcription factor gene on chromosome 11, that is FLI1 gene on chromosome 11. They fuse together and form a fusion gene, and this fusion gene will encode a chimeric protein, chimeric EWS FLI1 protein, and this protein binds to this chimeric protein binds to the chromatin and dysregulate transcription process, and through uncertain mechanism there is uncontrolled growth of the cell and abnormal differentiation of the cells. In minority of the cases, other chromosomal translocations are also noted, and fusion with the ETV, FEV and ERG gene are also seen. The Ewing sarcoma arises in the medullary cavity and invades the cortex, periosteum, and also goes into the surroundings of tissue. These tumors are soft, fleshy, ill-defined, grey-white or tan-white in color, and studded by areas of hemorrhage and necrosis which are frequent, and there may be some pus-like area present. The illustration on the left is showing Ewing sarcoma, which is showing that this is a diaphyseal tumor which affects the shaft of the bone, and this shaft is widened due to development of the tumor, and the tumor surface is necrotic and there are areas of hemorrhage. The cut surface of the tumor is shown on the right side, and it is showing that this is a grey-white soft friable tumor with areas of cystic degeneration. This is the Ewing sarcoma in a fibula, and the tumor is breaking through the cortex. The tan grey-white colored tumor tissue has prominent areas of reddish hemorrhage and brownish necrosis. On the right side, this yellowish area is the fatty bone marrow. This is another gross picture of the Ewing sarcoma, which is showing extensive involvement of the medulla and cortex associated with elevation of the periosteum. The tumor margins are ill-defined. The tumor is composed of solid sheets of cells divided by fibrous strands. Individual cells are small and uniform. The cellular outlines are indistinct and they may give appearance like syncytium. The nuclei of these cells are round with frequent indentations. The nucleoli are smaller and mitosis is brisk. The vascular network is well developed in these tumors. Sometimes the neoplastic cell arrange themselves around a vessel and forms a pseudo-rosette-like structure. And exceptionally, true rosettes are also formed, which are termed as Homer-Wright rosette. These are neoplastic cells surrounding a central fibrillary core. Sometimes tumor cells become large and pleomorphic and termed as large cell variant of this Ewing sarcoma. Another pattern is filigree pattern, in which the tumor displays an organite pattern characterized by bicellular strands of tissue separated by filmy vascular stroma. The other round blue cell tumors can be memorized by the mnemonic lemon, and the other round blue cell tumors are lymphoma, Ewing sarcoma, medulloblastoma, oat cell tumor, and neuroblastoma. Illustration on the left is showing the characteristic morphology of the Ewing sarcoma. There is presence of sheets of tumor cells. These tumor cells are small blue cells. They are separated by fibrovascular tissue, and the areas of necrosis is frequent. On the right, this photomicrograph is showing a tumor which is showing pseudo rosette. These tumor neoplastic cells, they are periodic acid Schiff reagent positive, and they are arranged in around a vessel. So we can summarize that these tumors are composed of sheets of the neoplastic cell which are closely packed. These neoplastic cells are round with little cytoplasm, and size of these neoplastic cell is about twice of a lymphocyte. These sheets of the neoplastic cells are separated by the fibrous septi, and on immunohistochemistry these are positive for CD99 and FLI1. The radiological appearance of the Ewing sarcoma is variable and depend on the host bone and tumor interactions. There may be destructive lesion, expansile tumors with permeative or moth-eaten margins that extend into the surrounding soft tissue. The characteristic periosteal reaction produces layer of reactive bone deposition in an onion skin fashion. So this X-ray is showing in the shaft of the femur, diaphysis of the femur, there is this expansile growth, the latex lesion with moth-eaten appearance, and the new bone is deposited in onion skin fashion. This radiograph is showing an ill-defined growth in the fibular diaphysis with a prominent periosteal reaction. There is thickening and widening of the medullary canal also. This is MRI which is showing Ewing sarcoma. There is irregular bright tumor extending from the fibula into the surrounding soft tissue. The normal bone cortex of the tibia is dark, and whereas the marrow cavity filled with the fatty marrow is bright. The Ewing sarcoma is spread through direct extension or goes to the other bones also. It goes to the skull in about 50 to 75% of the cases. There are cases of vascular and lymphatic dissemination also, and it goes to liver, lung, bone and brain. Intraspinal seeding also occur. The treatment of the Ewing sarcoma is neoadjuvant chemotherapy followed by surgical excision and adjuvant chemotherapy with or without irradiation. Prognosis is 75% 5-year survival rate and 50% long-term cure rates. Chemotherapy-induced necrosis is a positive prognostic factor. There are other factors which are associated with prognosis, and we are going to see all these in short while. The recurrence rate is about 30% within first 5 years of the treatment. Various factors which are associated with prognosis have been identified. The surgical margin is not related with the prognosis if the chemotherapy is used as a treatment modality. The osseous tumor, therapy-induced necrosis, type of gene fusion transcript, that is EWS and FLI1 type, and DNA content if it is diploid, are better prognostic indicators, while the soft tissue extension, metastasis, filigree pattern, neural differentiation and expression of TP53, MYC and INK4A are bad prognostic indicators. Giant cell tumors of the bone are also termed as osteoclastoma. They are characterized by the presence of numerous multinucleated osteoclast-like giant cells. in a background of epithelioid to spindle-shaped mononuclear cells. They are locally aggressive and benign tumor. They affect during third to fifth decades of the life, and the mostly the women are the victim of this disease. The disease is more common in Oriental countries, and it develops within the epiphysis and may extend into the metaphysis. Mostly the lesion develop at the junction of the epiphysis and metaphysis. Knee joint or around the knee joint, distal femur and proximal tibia, sacrum and distal radius are the common sites of this tumor. The knee joint only account for more than 50% of the cases. Least common sites are ankle joint, vertebrae and shoulder joint. But virtually any bone can be involved by this giant cell tumor. This giant cell tumor is frequently associated with Paget's disease and presents with arthritis-like symptoms or pathologic fracture. The giant cell tumors or osteoclastoma are composed of two types of these cells. One are the non-neoplastic osteoclasts and another are the neoplastic primitive osteoblast precursors. There is mutation in H3F3A and H3F3B genes which encode histone 3.3, and these histone 3.3 are chromatin packaging proteins. By unknown mechanism, these mutations are responsible for increased rank ligand expression on the primitive osteoblast precursor, and this increased rank ligand expression will lead to activation of the osteoclast, which through nuclear factor kappa B they proliferate and differentiate into mature osteoclast. Normally there is feedback inhibition by these osteoclasts to these osteoblasts, but when these mutations are present, this feedback inhibition is lost, and the mature osteoclast they continue the localized destruction of the bone resorption. The size of the giant cell tumor or osteoclastoma is variable. The giant cell tumor is the destructive lesion, so it destroys the overlying cortex, resulting in bulging soft tissue mass that is delineated by a thin shell of the reactive bone. When this is sufficiently large, it may produce or present with a pathologic fracture. The lesion of these osteoclastoma or giant cell tumor is large, peripheral, expansile, well circumscribed. There are areas of hemorrhage or red-brown appearance, and there is formation of cysts with necrosis. The cortex is thinned out and may appear fleshy white or pink or yellow in areas of foam cells. This is a giant cell tumor in the proximal femur. The femur has been cut longitudinally, and there is an irregular dark red blackish hemorrhagic mass which is arising within the epiphysis and extending into the metaphysis. This is another giant cell tumor. This tumor is located in the ulna, and tumor is well circumscribed, expansile, and showing brownish red discoloration. This is another picture of the giant cell tumor in the lower end of the femur. More than 50% of the giant cell tumor are located around knee joint, that is lower end of the femur and upper end of the tibia. This lesion is very hemorrhagic, and it has destroyed the cortex and extending into the adjacent soft tissue. The giant cell tumor of the distal radius, which is another common site for this tumor, the lesion is large peripheral expansile, and that is well circumscribed, and the cut surface is showing the red brown and areas of necrosis, and the cortex is thinned. The term osteoclastoma or giant cell tumor is a misnomer, as the malignant cell in this giant cell tumor or osteoclastoma are not osteoclasts. The malignant cell is a uniform oval mononuclear cell which lie abundantly in the background of these osteoclasts. The osteoclasts contain 100 or more than 100 nuclei in them, and there is presence of necrosis and mitotic activity which may be prominent, and the reactive bone is formed at the periphery. Tumor cells do not synthesize bone or cartilage, and there can be associated aneurysmal bone cyst component. Foam cells with the spindling of the mononuclear cell is also seen. There is no chondrite differentiation and no atypia usually seen. So the giant cell containing tumor of the or the lesions of the bone are chondroblastoma, brown tumor of the hypoparathyroidism, reparative giant cell tumor, aneurysmal bone cyst, and metaphyseal fibrous defect. This is a high power view of a giant cell tumor, which is showing these large giant cells containing dozens of the nuclei. Normally the osteoclast contain about 6 to 12 or 20, up to 20 nuclei, but here these giant cells contain dozens of the nuclei, and they are lying in a background of the mononuclear cells. The mononuclear cells are actually the malignant cells. In some instances, rarely the giant cell tumor have abundant spindle cells, and this may mimic fibrosarcoma. However, the giant cell tumor lack nuclear atypia and are more cellular than the low-grade sarcomas. The secondary aneurysmal bone cyst formation is another feature, and this giant cell tumor is perhaps the most common bone tumor associated with secondary aneurysmal bone cyst. Rarely, these secondary bone cyst elements may predominate. Then the giant cell tumor show aggregates of foam cell and spindle shaped cell proliferation. The typical areas of giant cell tumor may sometimes be inconspicuous. Such cases may be misdiagnosed as histiocytoma. Typical appearance of a giant cell tumor on X-ray. This radiograph is showing that the distal end of the femur is affected, and the epiphysis and the metaphysis, both areas are involved by this lytic lesion. This radiograph is showing a predominantly lytic lesion in the proximal fibula, which is expansile in nature and destroying the cortex also. There is a pathologic fracture present. The giant cell tumor are lytic expansile lesion of the epiphysis extending to the articular cartilage, and there is no matrix formation, and these lesions tend to be surrounded by a thin bony shell that is termed as eggshell ossification. Often these lesions are multiloculated, and hence radiologically they represent as soap bubble appearance, representing endosteal resorption of the bone. On the left, this radiograph is showing a multiloculated lesion of the distal radius, while on the right radiograph is showing the characteristic appearance of this giant cell tumor in the proximal tibia. This is a CT image of the giant cell tumor involving the left ischial ramus of the pelvis and appear as an eccentric expansile lytic tumor. There is extension into the adjacence of tissue also. As the tumor expands, it produces a bright rim of overlying new bone that is marked by this golden arrow. The treatment for the giant cell tumor is curettage, bone grafting, and block resection or amputation. They can be treated medically by the rank ligand inhibitor such as denosumab, or radiotherapy can be used as a treatment modality for the unresectable cases such as osteoclastoma affecting the spines. The recurrence is common in about 40 to 60% of the cases, and this recurrence and spread is more in tumors which express TP53. 4% of the tumor they spread to the lung, but they regress spontaneously over time. They are seldom fatal even after the metastasis. The malignant transformation is seen in 1% of the cases, and this malignant transformation is sarcomatous in nature. It may occur spontaneously or after the local radiation therapy. All giant cell tumor of the bone are low-grade malignancies because of their tendency to recur and their occasional capacity to metastasize regardless of the histological appearance. But a malignant counterpart of the giant cell tumor has been recognized and termed as malignant giant cell tumor, and this is the lesion that retains all clinical, topographic and general microscopic feature of giant cell tumor, but they show clear-cut evidence of malignancy in the mononuclear stromal component, and these are basically equivalent to the grade 3 giant cell tumor. The picture A is showing that there is a giant cell tumor in the lower end of the femur that has been treated by the bone chips and curettage and bone chips, and then there was recurrence of the tumor in the same place, and the cross appearance of the picture in picture B is showing that there is the presence of bone chips along with the newly developing tumor. The picture C is showing the previous or earlier tumor that is clearly showing that it is a giant cell tumor with the abundance of the giant cell with a mononuclear cell background. But D is showing another morphology, that is the development of fibrosarcoma like picture. The high-grade sarcoma can develop at the site of previously treated giant cell tumor. Aneurysm means dilatation or distension. The aneurysmal bone cyst is an uncommon benign expansile and destructive lesion arising within a bone or its surface. These are usually multiloculated blood-filled spaces, and they are benign but locally aggressive benign tumor. They affect all age group, but most common in adolescence. The peak incidence of this aneurysmal bone cyst is in the second decade of the life with slight female preponderance. The site of this aneurysmal bone cyst is metaphysis of the posterior vertebrae, flat bones, shaft of long bones, and rarely cases of this aneurysmal bone cyst are reported in the wall of the major artery or within the soft tissue. This picture is showing these dark blue areas are showing the typical sites for this aneurysmal bone cyst. The typical sites are around the knee joint, upper end of the femur, sacrum, vertebrae, while the less typical areas are the shoulder joint, around the shoulder joint, around the wrist joint, and the ankle, also the ilium. The aneurysmal bone cyst may occur secondary to the trauma or arise in pre-existing bone lesions such as giant cell tumor, chondroblastoma, and fibrous dysplasia, and they present with localized pain and swelling that may result in limping, vertebral lesion, and nerve compression. 70% of the cases of these aneurysmal bone cysts are associated with chromosomal rearrangement. There is translocation between chromosome 16 and 17 within the plump spindle-shaped cells. The USP6 coding region is present on the short arm of the chromosome 17, while cadherin osteoblast promoter gene is located on the long arm of the chromosome 16. When there is the fusion of these two genes and these USP coding region fuse with the cadherin promoter gene, they, as the cadherin are expressed on the osteoblast, and USP6 encode ubiquitin specific proteases that regulate the activity of nuclear factor kappa B, that will result in increased expression of the proteins that are the matrix metalloproteases, and these increased expression of the matrix metalloproteases, there is resorption of the bone in the cystic form. Beside this fusion of the USP6 with the cadherin 11, there are other genes which fuse with the USP6 coding region. These are ZNF9, that is zinc finger 9, collagen 1A1 gene, TRAP150, that is thyroid receptor associated protein 150, and OMD osteomodulin gene. All these result in the development of the aneurysmal bone cyst. Then in few cases this lesion is associated with trauma, fracture, or subperiosteal hematoma, or in some cases it arises in the pre-existing bone lesion as a result of changed hemodynamics. The condition in which it occurs secondarily are chondroblastoma, giant cell tumor, fibrous dysplasia, non-ossifying fibroma, osteoblastoma, chondrosarcoma, and in the vascular and cartilaginous hematoma of the chest wall in infant. In these secondary types of this aneurysmal bone cyst, the genetic aberrations are not seen. The morphology of the aneurysmal bone cyst is characterized by the presence of multiple blood-filled cystic spaces that are separated by the thin tan white septi, and the cut surface of the cyst resembles a sponge that is permeated with the blood and blood clot. There are fleshy aggregates of the tumor surrounding these cystic spaces. The breakdown of the blood into hemosiderin leads to the brownish staining of some of the cysts, and some of the septi between these cysts contain bony tissue also. The illustration on the left is showing the presence of multiple blood-filled cysts, aneurysmal spaces, that are separated by the fibrous septi, and these are the characteristics of the aneurysmal bone cyst. While on the right, this gross appearance of the aneurysmal bone cyst of the ulna is showing that at the end of the long bone there is expansion and lysis, while the inner wall of the cyst is thin and hemorrhagic. This is the aneurysmal bone cyst of the proximal ulna. On the left, this gross specimen is showing that it is a spongy hemorrhagic mass that is covered by thin shell of the reactive bone, and this may extend into adjacents of tissue, while on the right the same lesion radiograph shows that there is eccentric expansion of the bone with erosion and destruction of the cortex, and there is formation of a small peripheral area of periosteal new bone. A solid variant of the aneurysmal bone cyst has also been described, and which is characterized by the presence of solid area and presence of some cystic spaces or hemorrhagic cystic spaces at the periphery. Histologic appearance of the aneurysmal bone cyst. The septi are composed of plump spindle cells, multinucleated osteoclast-like giant cells, and a reactive woven bone lined by the osteoblast. Bone deposition follows the contour of the fibrous septi, and 1/3 of the cases contain an unusual densely calcified basophilic matrix that is termed as blue bone, and necrosis is uncommon unless pathologic fracture is present. This is a high power view of an aneurysmal bone cyst. On the lower right, there is presence of the RBCs, and within these RBCs there is pale brown hemocentrin also, and they give the gross appearance of red to brown color, and these lakes of RBCs are bound by the septal proliferation of fibroblast. These are mitotically active spindle cells with TRE17 expression, osteoid in the woven bone, and osteoclast-like giant cells are also seen in the septi. The aneurysmal bone cyst is characterized by the presence of large cystic spaces separated by the septi, which contain giant cell and spindle cell, as it is evident by this photomicrograph of the aneurysmal bone cyst. These spaces are filled with blood and lack and endothelial lining. The thin strands of the bone may be present in the septi of these aneurysmal bone cysts, and there are clusters of giant cells in a background of spindle cell proliferation. This picture is showing an aneurysmal bone cyst, high power view of the aneurysmal bone cyst, which is showing that there is clusters of the giant cell with a background of spindle cell proliferation within the septi, and there is vascular proliferation also. This is the radiological appearance of the aneurysmal bone cyst, which is characterized by the eccentric expansion of the bone with erosion and destruction of the cortex, and there is a small peripheral area of the periosteal new bone formation. This is the aneurysmal bone cyst in the lower end of the fibula. This is the aneurysmal bone cyst in the distal femur with an eccentric expansile lytic lesion with a well-defined margin that is composed of thin shell of reactive bone marked by this red arrow, and there are internal septations also which are marked by golden arrow. On the left, there is a coronal section of the CT image of an aneurysmal bone cyst affecting the upper end of the tibia, and the cyst is confined by a thin rim of reactive subperiosteal bone, while on the right there is this axial image of the MRI, and it is showing the fluid level within the cysts. The treatment for this aneurysmal bone cyst is curettage and excision with bone grafting. The lesion in the axial skeleton such as pelvis and vertebrae are treated by selective arterial embolization. The recurrence rate is 10 to 50%. However, some authors state that it is more than 70%. The malignant transformation is rare, and when occur, it transforms to osteosarcoma, and prognosis is excellent. Myeloma can be localized or diffuse, and they produce lytic lesion in the bone, and they affect older age group, more than 65 years of age, and male are twice as common affected as female, and the lesion that they produce are due to the myeloma cell. These myeloma cells, they secrete cytokines. They are responsible for the recruitment of the osteoclast, and the osteoclast recruitment is responsible for the lysis of the bone. The commonly affected bone are skull, spine, ribs, pelvis, and femur, and they present with pathologic fracture also. The microscopy is characterized by presence of sheets of plasma cells showing varying degree of maturity, and one important complication is the deposition of the amyloid in 10% of the cases, both within the skeleton and extraskeletal side. The survival with treatment is about 5 years, but the cause of death is infection or renal failure. The 5-year survival for these myeloma patients is about 60%. Chordoma is a notochordal tumor, and these notochordal tumor accounts for about 5% of the primary bone tumors. They are slow-growing malignant tumor arising from the notochord remnants, and this notochord is the primitive axial skeleton which subsequently develop into the spine. Normally, remnants of notochord are presented by the notochord or physelliferous, which means bubble-bearing cells present in the nucleus pulposus and few clumps within the vertebral bodies. The site for this chordoma is axial skeleton, sacrum, and coccyx in 50% of the cases. It's spheno-occipital region in 35% cases, and less often in spine. It is about 15% of the cases. It affects people after the age of 40 years and without any gender preponderance. Radiologically, they present with osteolytic lesion and may present with symptoms of spinal cord compression. These are slowly growing tumors which infiltrate in the adjacent structure, and metastasis is rare. The treatment of these chordomas is excision. However, the recurrence is frequent. The chordoma grossly is soft, lobulated, translucent, and gelatinous with areas of hemorrhage. The cut surface is fleshy with invasion into the surrounding tissue. It is histologically composed of highly vacuolated physelliferous cells which are surrounded by the sea of intercellular mucoid material. Histologically, it should be differentiated from the chondrosarcoma and mucin secreting carcinomas, and it is differentiated by positive cytokeratin and S100 immunostains. Now, returning to the case scenario we discussed in the start of this video, a 32-year-old woman present to your office complaining of pain in her right knee joint. Physical examination revealed no evidence of infection, and X-ray showed a mass in the knee with soap bubble appearance at the distal end of the femur involving epiphysis and metaphyseal area. The diagnosis of this case probably is giant cell tumor. The another case scenario was an 11-year-old boy presents to your office complaining of painful swollen mass in right leg. He denies any history of the trauma to the leg. Laboratory tests showed anemia, leukocytosis and increased erythrocyte sedimentation rate, while X-ray revealed a latex tumor with an onion skin appearance in the medullary cavity of his right femur. So the diagnosis for this case scenario is